going to invite Jeannette Lynn back up to talk about our process for planning for these patients once they're listed for transplant.
Thank you, Lee. So I'm going to spend the next hopefully 10 or 15 minutes here just going over one of the key parts of our process here at UCLA that we found to be really beneficial in trying to guide these patients safely through transplant. And so we wanted to make sure to emphasize this part of our process, especially with those of you in the audience who may be building transplant programs for these patients at your home institutions. So the multidisciplinary operative planning, when do we do it? What's the rationale for it? Who needs to be involved? And what questions are we talking about during this planning meeting? So we've walked throughout the course of the morning and this early afternoon through these different steps in the process, right? So we started with our stable Fontan patient. We're doing surveillance and optimization. The failing Fontan patient, we're trying to use our interventions, our medications to try to stabilize them. Again, trying to slow that train that may be headed towards an end-stage process. We then have our failed Fontan, for whom, in spite of our interventions and best efforts, is declining. And at that point, we're thinking about whether or not they should be considered and can be considered for a transplant, or if we should be thinking about a more palliative approach for the patient. If we do decide to go down the transplant route, then there's a transplant evaluation. And those of you who come from transplant centers or are from here at UCLA understand that process that Dr. Boss has also covered. This involves evaluation by multiple specialists, including our cardiac surgery team. If the patient's being considered for a liver transplant as well, then they're also evaluated obviously by the hepatologist and the liver transplant team, the social workers, infectious disease, nephrology, pulmonology, all of these individuals, cardiomyopathy team, are all involved in doing their own individualized assessments of the patient. Now, Dr. Boss talked about the formal committee review, which is down here, but even before we get to the formal committee review, we do actually a pre-review. So as you can see, there's a lot of steps here. And the reason we started doing this pre-review meeting before the formal committee review is that the formal committee review, again, for those of you who've been in these meetings, are actually fairly brief. Even for the most complex patients, you have 5 minutes, 10 minutes, maybe 15 minutes to go over all of the details of these really, really complex patients. And that's not just not enough time to do justice to the complexity of these cases in the formal committee review. And so we've taken it upon ourselves to do a pre-review meeting where we bring in all of the different people who need to give an opinion about the patient's candidacy for transplant. And this typically involves the adult congenital heart disease team, the heart failure transplant team, the congenital cardiac and transplant surgery team, the hepatologist, the liver transplant team, and again, as needed, pulmonary, nephrology, and infectious disease. And in this pre-review meeting, we go over as much detail as possible. We're looking at the patient's surgical history, we look at chest anatomy, we look at all of these things to decide, do we think that transplant is the right thing for this patient? The patient then goes to the formal committee review if we decide that that really is the next best step for the patient. And at this formal committee review, that's when they get formally reviewed by the Heart Transplant Committee. And at the Heart Transplant Committee are usually these individuals that we just talked about, but also a lot of people who've never met the patient, but who also have a vote and a say in whether or not this patient gets listed. And so we always want to have our ducks in a row, and we get that done in this pre-review meeting, and then we bring all of that to the transplant committee meeting. We do a very concise presentation. The surgeons weigh in, the cardiomyopathy, adult congenital teams weigh in, all the different specialists weigh in, and then we make a decision at that point about whether or not to go ahead and list the patient for heart transplant. The heart transplant is considered the primary organ. The liver is considered the secondary organ. So the patient goes to the liver transplant committee after they've been accepted by the heart transplant committee. So now we've gone through all of those steps, and we've decided that this patient is appropriate and acceptable and now can be listed for a heart-liver transplant. So now we're at the operative planning meeting. So why do we need to have an operative planning meeting? What's the purpose of this? This is so many meetings I've already talked about for this one patient. Well, having an operative planning meeting is really important because the reality is it takes people a lot of time to learn how to work together, right? It might take 5, 6, 7, 10 cases for a liver transplant team and a cardiac transplant team to really iron things out, but we don't have the luxury of 5 or 10 patients to iron things out. We want to get it right the first time. And so having this meeting, bringing all the different people together in the same room to actually go over the logistics of how we're going to do this is actually really important. So in this multidisciplinary operative meeting, who do we bring in? We bring in, obviously, our cardiac surgeons, cardiac anesthesiologists, who are going to be working in the case side by side with the liver anesthesiology team. And we're going to hear more from the cardiac anesthesia and liver anesthesia perspectives later in the afternoon. We're bringing the liver transplant surgery team, perfusionists, very importantly, as Dr. Boss pointed out earlier, the CT ICU team, who's going to be receiving this patient and needs to know how all of the different services want to manage this patient. And of course, oftentimes this is all being driven by our adult congenital heart disease team, since we're the folks who have known the patients the longest and provide continuity very much throughout this process. So we're trying here to short circuit this getting to know you, getting to learning how to work together process. And again, the reason is because the communication is important. Oh, so when I asked you if I should make a left turn and you said, right, you meant as incorrect, yeah, I totally misunderstood that. One wrong turn and we are off a cliff in a way that can be irrecoverable. And this is the matter of life and death for these patients. And so we want to make sure, again, that we get all of our ducks in a row, that we know what we're getting into when we when our surgeons step into the operating room. So what are we talking about during the multidisciplinary operative planning meeting? So we start by talking about managing chest reentry and bleeding risk. We always do chest imaging looking for retrosternal distances and look for the hostile chest. As we've talked about before, we want to look at the femoral vessels and see if they're patent for peripheral cannulation. This is a point that we've talked about several times today. We cannot emphasize it enough, and so we will continue to emphasize it for the rest of the afternoon, is the closing of veno-venous collaterals and aortopulmonary collaterals to minimize bleeding risks. And we feel like this has really made a big difference in terms of our last several cases in ensuring safety and success. If we could click on those two videos, we can play them, starting with the one on the left. This is an example of a patient who went to heart-liver transplant, a Fontan patient, a couple of years ago, and so you see this enormous, like 22 millimeter collateral that's coming here from the abdomen. If we click on it one more time, we'll see that the patient, starting in the patient's abdomen, we get the epicardial pacemaker, pulse generator, this huge collateral which comes up, turns rightwards, goes posteriorly, and drains into a pulmonary vein. So that's a huge collateral, which could cause major bleeding problems at the time of a transplant. So if we look at this right clip here, we can see that Dr. Abelhusen has put a big plug in here, and there's still some flow, but over time that will clot off, and hopefully there'll be no more flow through that collateral. But again, this is part of our operative planning to try to shepherd our patients safely through surgery. We'll also talk about, as Dr. Boss has mentioned, how do we coordinate things? How do we coordinate when the harvest is done, when we're going to be ready to receive the organ in the OR? And importantly, we want there to be enough time to dry the chest. These are patients who've had oftentimes 3, 4, 5 sternotomies. There's a tremendous amount of scar. And even when we take out a lot of these extra collaterals, there can still be a lot of bleeding. And we want to make sure that when the donor organ gets to us, that we're ready for it, and the donor heart isn't sitting around while we're still trying to dry the chest. We'll talk more about optimizing renal perfusion and decongesting the patient. Dr. Cruz will be discussing that in the next session, in the next talk. Other things to talk about at this multidisciplinary operative planning meeting, listing parameters. As Dr. Voss has pointed out, we have to decide what's our maximal acceptable ischemia time, and from there we work backwards and figure out what's the maximum distance that we're willing to have the organ travel. We tend to be very stringent for our complex patients and limit the distance to somewhere between 300 and 500 mile range. It does mean that these patients will wait potentially much longer for an organ because we're being so restrictive about the range from which we're willing to accept organs, but we feel like this is important for making sure that the organ goes in and is functioning well when it goes in. Standard listing parameters usually involve height ratios and weight ratios, but there are limitations to this approach, and as we move forward, we should be thinking about, are there better ways to try to match donor size and recipient size? And there's now data out there to suggest that using a predicted heart mass as derived from MRI calculations in this complicated equation that you see over here can be a much better guide for us to use in terms of trying to find the right donor size and the right recipient. There are also unique anatomic considerations in the congenital heart patients, specifically patients with dextrocardia, or a patient with heterotaxy. And so both surgeons need to be on board about how they're going to work with the patient's unique anatomy. So there's limited real estate. The idea is that there's only so much space in the operating room. This is a picture of what the space around an operating room table looks like and how crowded it can feel sometimes, I think, in the operating room when you now have not just a regular one transplant team, but two transplant teams having to work side by side, 2 cardiac surgeons, 2 liver transplant surgeons, scrub nurses, and trays for each specific organ. So what other questions do we need to address? And there's going to be more talks about this topic soon, but the questions that we want to address at the multidisciplinary operative planning meeting: will the patient stay on cardiopulmonary bypass during the liver transplant? What immunosuppressants are we giving and when? We don't want to duplicate immunosuppressants. What are our strategies going to be if there's severe bleeding, as there oftentimes is in liver transplantation? What are we going to do for intraoperative and early postoperative renal support and volume management? What is the early post-transplant management in the CT ICU going to look like? And this is a problem that we certainly encountered. As you can imagine, that's a lot of teams coming by and rounding on the patient every day after a transplant. They're coming in at different times of the day, each giving their opinions and then going about their day. The CT ICU team is the one who's trying to balance all of these recommendations and actually care for the patient at the bedside. So that can be challenging as well. So I've gone over in the last 13 minutes here the rationale for a multidisciplinary operative planning meeting, talking about teams working together for the first time and trying to shortcut that process so that they can learn to work together from the first case that they do together. And I would also mention that if you are doing this at your institution, you will, after several cases, start to get a sense of what you want your protocol to be. And that will eventually become the default protocol at your hospital, but we would still recommend, and we still do here, review every case individually to make sure that our protocol makes sense for that patient. Another time to revisit the protocol is if there's obviously any change in the core staff. If there's a new liver surgeon, a new cardiac surgeon, expect that you're going to need to revisit this again to bring everybody together on the same page. We've talked about who needs to be involved and why, and what questions should be discussed. So with that, I'll turn it over to more excellent talks.